Johan Gustav Bellika. Yeah. From the University of Tromsø, Norway. And he's declared the Ehealth system and information needs for all physicians.
Okay, I'm Gustav. Thanks for the opportunity to come and talk about my favorite topic. So this paper was written together with the center and a physician, and that's located at the Norwegian Center for Integrated Care and Telemedicine. So I'll just jump into it. This one? No? Okay. So the objective for this paper was to identify the constraints that need to be satisfied and the resources that we need to build successful e-health services that may survive the transition to large-scale routine use. So what's happening in Scandinavia is that we have been working in the field of telemedicine and e-health for a very long time, but we haven't really seen that these services go into large-scale use. There are newspaper stories in both in Denmark, in Norway, asking why haven't this happened? Why aren't every physician using telemedicine and e-health? And so this was the background of why we looked into this. So I'll tell you a little bit about telemedicine and how I look at telemedicine and e-health solution. I'm a teacher at the University of Tromsø in telemedicine and e-health, and I'll explain a little bit about this, what we call the equation. So in this equation we have some persons and we have some computers that communicate using these networks to another computer that presents something to a doctor. So in e-health, when I talk about e-health, I usually mean that there is a patient, this guy, using his computer or his laptop or something to communicate to the physician's system here. And this is the physician. So this is what I normally think about when I say e-health. There's a patient and there's a health worker. In telemedicine, I think about, normally refer to that when this guy here at this side is a health worker collaborating with somebody in another place in the health service. Normally, this guy is a specialist, a medical specialist in a hospital that helps out. And of course, the question when we do research is this part on this side better than this side? Two persons talking together in one physical location. If we look at the roles here, normally in e-health solutions and telemedicine as well, there is one part that documents the case. It could be the patient or it could be the primary care physician. That documentation is forwarded to the one with more competence, more skilled person. In e-health, this is the physician, and he makes the decision. So there are two parts: there is documentation and there is decision making. And the question, of course, is whether this is better than physical meeting. And the lines here, they are the communication, which gives us the words, the distance between maybe the patient and the general practitioner, or between the general practitioner and the specialist. Okay, I can talk very long about this equation, but I think I'll stop there and move on to more about the background. So, telemedicine and e-health system we have not achieved the large-scale adoption that we were hoping for, and we spent more than 20 years on researching solutions for this. There are some success stories. Teleradiology is one of them. The University Hospital in Tromsø was the first in Europe to actually be fully digitized. And this is a huge success. And they early built networks to exchange the images between health institutions. Also, messaging systems to exchange referrals, discharge letters, and so on is also a huge success. Most part of exchange between health institutions is done today using messages. Video conferencing is also a success, I would say. It's not as big as the two other ones, but the requirements for managing this kind of services are greater, and the investments are also higher in this kind of services. So why haven't we really achieved the big adoption of these services? And one reason may be that the focus of the research has been in the hospitals and focusing on the chronic care patients. So currently there is a lack of focus on the primary care physician's role and his needs, and the primary communication partner for the physician, patient. And normally we focus on maybe chronic care and not the easy cases that easily could be converted into maybe self-care. So if we look at it, this in the pyramid, this is how the Norwegian system looks like. It's similar to the Spanish one, and this is where the traditional focus is. And of course, when maybe only 10% of the patients ever go to a hospital, then we cannot really have large volumes. While in the bottom of the pyramid here, self-care, the people taking care of themselves, there's a huge potential there. There was a study in the UK that said that about 30 million consultations every year potentially could have been converted into self-care. That's a huge potential. So I would to find a service that really could be large scale. I would look at the bottom part of this pyramid and see whether it's possible by using e-health services between general practitioners and patients to really have large scale use to achieve maybe more self-care as well. So looking into this, was a recent review looking into this communication of symptoms between health patients and the health service, and there have been done 29 studies. That's not a lot. And of these 29 studies, there were one focusing on communication of symptoms between patients and primary care physicians, and it was done in Spain, actually. There were 6 studies that focused on, is the patient, by giving him information and guidelines, is it possible to convert this into self-care, sometimes supported by physicians and nurses. 6 studies. But most of the studies that were done, they were focused on chronic care patients. So chronic care and hospitals, that's where the focus have been in this field. The references you can see below. So the method for this paper is I'm going to explain it here. And if we want to find this high volume, large volume services, we need to look where we haven't looked yet. So that's what basically what I just did. Explain to you where the high volumes of interactions already are. So what we did was more or less follows what we do when we do software engineering. We start with an analysis phase to identify the constraints for a solution. And using our knowledge and experience, we sort of try to form a direction for future research. So the outcome is a proposal of a new direction for focus of research in this field, and 5 recommendations for actions that could take us in this direction. Some critique is appropriate, I think. There is no guarantee for success or large-scale adoption here. We don't know that, but I think that if we look where there already is a large number of interactions, maybe we can find some good solutions. Well, the validity of our claims and the basis as well is weak, and we need to strengthen this before we go in this direction. So we have no data from primary care physicians. We should ask them what they think. So ideas for new systems cannot be proved. So this is what I guess most computer scientists already know, that it's hard to prove the future. So this also goes for our recommendations. So looking into the results, what constraints did we identify for large-scale Ehealth solutions? So these are the constraints. I won't go into all the details. That you can read the paper and see there, but I will talk about 2 of these in a little bit more detail. First of all, the Ehealth solutions need to satisfy some information needs. I'll go into that, what I mean by that. There are different disease episode types which have different needs. Disease prevalence, we should aim for the large ones because most people have those. And computer literacy raise some demand for the usability of these new services, both for patients and for health workers. And I'll also talk a little bit about computer usage during patient consultations, which depends sort of the disease, what kind of disease episodes we're talking about. So the solution must satisfy the information needs, and according to Gorman, there are 5 different things that physicians need. But most systems focus on patient data. You need the patient data to have a system. But there are other things that we could include here. We could include population statistics, for instance, epidemiology, disease surveillance systems that could guide the decisions of the physicians. Medical knowledge could be linked in here. If we have some suggestions about what the cause of the disease are, maybe we can link in something from up-to-date or videos or whatever. Logistic information, of course, procedure, guidelines, how to treat the patient can be linked in. And also this social influence, how do the doctors treat their patients, statistics about that. And all this we can generate from one source. It's the EHR system that physicians use. It's in Norway. There is no reuse almost at all from the electronic health record system that's out there. They put the data in and it's never used again. And that is it's a huge potential in reusing that data for Ehealth systems. The patient data that we see here, they could provide a context that makes the above information categories relevant, because physicians don't want to look through large web pages of procedure guidelines. They really need it to the point, connected to maybe possible causes for what this the patient is seeking advice for. So patient data can be the context. So computer usage during consultations. There are two broad categories here. There are the consultations for known conditions, like chronic diseases. But we also have this consultations for unknown conditions, and that's a bit more challenging. Currently, there is no Ehealth support for that area at all, as far as I know. And if we had such a solution, an Ehealth solution, maybe we could use this instead of the physical consultation, sort of moving the direction of self-care. Or we can use it before consultation or after the consultation. And my former supervisor, Tora Fasvold, who was dean at medical faculty in Tromsø, always said that the physician should concentrate on the patient, shouldn't handle the computer while diagnosing patients, because that is a demanding task that needs the full capacity of the physician. So the use cases that is developed in this situation, in meeting between the physician and the patient, there's no room for computers there. Need to be before or after. Was his position. So if you look at disease episodes today, this is what it looks like. There is a symptom W. There, the patient at some point books an appointment with a physician. Some more time go, and there is a consultation. And after a while, the patient becomes well, or there is a follow-up, or there is an intervention, maybe surgery or something else. And if you look at what data do we actually have in that time span, it's only during the consultation that we communicate data to the physician, and that is what he bases his decision on. So if we look at the same situation in a different way, we have a patient here with a disease process who's contacting the health worker and communicate the patient data to the health worker. Based on that data, the health worker makes a decision and do some action, maybe a drug or something. So when we introduced electronic health record system, the healthcare worker in primary care himself summarized the patient's symptom and put it into the electronic health record system. And there is a potential to use that information to provide population statistics, medical knowledge, logistic information, or work practice. However, a problem here is the quality of this abstracted patient data, which is a problem for reuse of this data. What has happened afterwards is what we see that the patients get their systems, public personal health records, and so on. And the potential here is that the patient enters the system, his symptoms into this system, and can get population statistics, medical knowledge, action advices, videos, and social statistics about how other patients did in a similar case, and get an advice pattern. The large potential, however, is that these symptoms can be communicated to the other side, to the medical information resource, effectively relieving the physician of some of the work in actually documenting the symptoms of the patient. This could provide a context for giving the advices to the physician for population statistics, medical knowledge, and so on. So this is what I see is happening. And what changes when we do that is we have some new possibilities, and the possibilities comes from documenting not only providing data in the consultation, but you can actually do that before. And you can also do that afterwards. So that you have a whole chain of data that documents the patient's case. And if we do this in the right way, we can maybe start processing on that data. And maybe we have more evidence to base our decisions on. Maybe we can also use computers on this. So, what becomes important here is that this patient data, which will grow, that we store this in a standardized way. And I propose that we use archetypes for that, so that we can expand the type of symptom that is communicated by the patient to whatever we want to document, and that these EHR systems on the physician side is able to read that. And maybe then when we have this going, this communication of symptoms between the patient and the physician, maybe we also can forward this to the next level, the specialist service, as a telemedicine service. So, some conclusion. I think there is a potential for large-scale solutions in primary care, but we need to sort of focus on maybe this easy that potentially could be self-care. An important constraint is that this solution must be more efficient than the current approach. If the new approaches demands more time from the physician, by the end of the day there will be a line outside his door, and he probably won't continue doing it this way. So we need efficient systems. More efficient than what he's doing today. The resources that we need a large collection of EHR data. We need to start reusing this to generate the information that the physician needs. Not only the patient data, but the medical knowledge, the logistic information, population statistics, and also this social dimension. What are other doctors doing with their patients? And also, we need to standardize the communication of the symptoms between the doctor and the patient. And archetype is a good candidate for that. So if we are able to have all these data points about the symptoms of the patient, and we also, if we're also able to get the actions, then we will build up huge collections of data that we can use to take this field further. Okay, here are the recommendations. So first of all, we need to identify what telemedicine and e-health systems primary care physicians need. So we need to start where the volume is high. And we need to focus on the patient-primary care physician collaboration and identify the most prevalent consultation adverse that is suitable for e-health. We should establish access to process this large volume of EHR data. We're currently working on that in Tromsø, try to achieve this, but it's very hard because of the sensitive nature of this data. We need to enable standardized representation of a large-scale collection of symptom data from patients. So this, I hope that we don't end up in a situation where this symptom data is scattered all over the place in silos where we can't really use it. We really need to put this in a place where we can use it as a resource to generate knowledge. And we need to integrate the e-health systems with the EHR system to establish this symptom action. And here are the references. And this is Tromsø. It looks probably like that up there. And, oh yeah, maybe midday. Yeah, so this is what I do for exercise. Climb the hills and ride down. Okay, thank you for your attention. Questions?
Any question?
In the recent years, especially in the United States, people, some persons, some important persons inside the public system wants that people empower about their care. How do you do that in Norway? Really, the people have power about their health?
Well, in Norway there is, we have a problem with the aging population, and we foresee that towards 2050 we will have double the demand for healthcare services, and we will have half the people available to treat the care. So this means that the healthcare workers currently in the service now, they need to run very, very fast. So this is not sustainable. It's clearly not sustainable. So there are two solutions. Either we don't care about people, or people care themselves, or have more responsibility of their own care. Oh, those are the alternatives. So I don't see that we can continue keeping the level of services as we have today. Because now 1 of 6 young students choose the health field. In the future, we need 1/3. 1/3 of all the kids coming out of school must go to the medical faculty, be nurse, to keep up. We cannot do that.
I understood also behind the question that there's another one that's is this electronic record being used for patient empowerment in the sense that all this data should be also available for the patient. You have a directive that allows and gives the right for the patient to have access to all this kind of electronic record, and at least this is useful just to know your status and also
To look for a specific reason. He knows the variability of his own state. He can ask for the real professional intervention or real consent.
Yes, we have that demand in Norway as well, and the government is working very hard to get the data in the electronic health record out to the patient. But I'm proposing the opposite way, because we really need to help the health workers. What I expect is if you give the data in the medical record to the patients, they will come to the physician and ask, what does this mean? We should rather maybe give them very good resources as videos from the university, hospital, or something else. I think people can learn from themselves. And there was one guy that works with managing these systems. He said that, well, putting all data into a personal health record, or many personal health records, is not very interesting, because what do you want to do with it? If you use it to find knowledge that you can use, then it's a good thing, I think. But for the patient, I think it's if I can communicate it to my doctor, then that's a good thing. If I'm the one that's responsible to get it to the next chain, that's a good thing. But I think that the healthcare service should do that themselves, solve that problem.
We are almost on time.
Huh?
We are almost on time.
Very good.
Very good.
one question. Maybe I'm interested in this because maybe there are some physicians on the room just because about the patient empowerment of not, because this this is something that's always a big place or issue for discussion even. I remember the group of the patient where also some doctors think or consider that if they are prescribing links or empowering the patient, some patients criticize him because they thought this is a lazy doctor that he doesn't want to perform his work. I mean, so even from the so I'm also aware of that. So as he and I said, technicians would like also to know your opinion about that, or maybe Frank also that he's also pushing for patient empowerment.
Most people don't understand the real capability of that service, of that device, of the new technology. And in our country, I feel that people need to receive care, but not to give themselves the care. I think that we can we need to teach people to be responsible, to take responsibility about themselves, but people really don't like to do it because in the daily world you see people that knows what happened with cancer, but don't take any decision about it. And it's very easy to repeat the same question and to do this every day, the same receipts for treat the same disease. Sometimes if you can automatize some process, you can the patient with the right program, you can prescribe some treatment and only review it if the treatment don't go but the right way. Yes, I think that with the new devices you can do that, but people really, I don't know if it's easy to interact with the people if they don't see the physician say, "Hi, Pepita, how are you? How do you feel?" Does that change? I think that is I think is a valid challenge to improve our introduction in the system. I don't know.
I do agree with you. Doing this will put a lot of demands on not only the system but also the patient. But the most exciting thing here is if the physicians say, well, you have to do this. If you want to come to me, I need your symptoms before you come. Good. So will the patient do it? I think they will. There was some, I don't remember exactly the reference, but there was somebody asked them, are you prepared to do this? And I think about 70% said yes, I will. But that was maybe a young population.
Okay. Johan, well, I consider that you cannot think that a physician is lazy is prescribing links, because I think it's harder to prescribe a proper link to which is adapted, the information is adapted to the patient that only, talking. But what we really need is support from our institutions, because not all physicians are ready to prescribe links, and we don't have, during university or post-university, we don't have any information about that. They don't teach us how to properly give links or any other e-health resources. Just talking about that, or even mobile health, which is now the trend. Now it's trendy to talk about smartphones and things like that, but we are not ready. It's something for which politicians make pictures of them in the media, but they don't really support that, and that is what I think we need. Support and to make concentration and teaching. And I agree with you. I was a little bit distracted, and that's why I don't know if it's what you wanted from me, but that's what I think from that.
I'm happy to go to the medical faculty and talk about this.
Sorry?
I'm happy to go to the medical faculty and talk about this.
Yeah, but I can do nothing about that because I'm not at the university. But I don't like to invite you. I would also like to talk about that in the university, but it's something now I think they consider us geek people who talk about this that is it's true, but it's not applicable to the real world. So when I go to give lectures about that, they smile at you like contestantly, like saying, yeah, but you are not living the real world. And I've worked as a physician a long time ago. But I think it is. And we have some examples in Spain, these techniques every day. But still we don't have the support from our institutions. It's sad. We only have they only use it for, for their interests, and they have their very expensive websites for giving their messages, their political messages, and they are not supporting the health messages, which I think are the most important. We have to live with them. They are necessary evil. We have to live with them. But it's a question of time, and I hope that in not very long time we become from geeks to normal people.
There was a question there.
I wish to remark another topic about the use of telemedicine system and Ehealth system by primary care. And is that perhaps now we haven't any technological problem or technological real problem. Perhaps the real problem about the implementation of in a real world of this system is how are we capable to integrate these new processes in the organizational flux, in the organizational work or real work, or not technological work. How has resolved this problem the health system in Norway or in other countries that are implementing this telemedicine system?
About telemedicine in Norway, we have tried a lot of different things. But when we come to the general practitioner, we often see that the number of cases that each physician sees for that very narrow field, there's too few cases, because we use this to deliver services in a rural site out in the area that is covered by the university hospital. So for each physician sitting in his office, maybe there is one patient a week, 2 patients a week, once a month. So the focus has been a very, very narrow field, which makes it not very relevant for the general physician practitioners to use this. And it's cumbersome, it's not integrated with the electronic health record. There's a lot of barriers to really take this into practical use. So, but some years ago there was a report that the primary care physicians actually went through all the list of, I think there were 280 different telemedicine projects he assessed. And they selected the things that they wanted to support by the prevalence. How many cases you have. So I think the prevalence of disease is the most important criteria because if you use something every day, you get accustomed to it, you're confident, and you want to do this. If it's easy, if it's efficient. If it's cumbersome, integrated is a special solution that you maybe use once, twice, 3 times a week. I'm not very optimistic.
I want to ask you, some private organizations first that kind of services in any way, in any kind of program, non-specific program?
In Norway?
In Norway.
Yeah, we have the Norwegian Center for Integrated Care Telemedicine. Their role is to develop the services. And when they have developed it, it's sort of moved out to be maintained by other institutions. That transition there is difficult, and a lot of the services don't survive that. So if somebody wants to build an institution, I think that maybe they should take care of actually running the services, having the physician there, and deliver the services from one institution that have the responsibility from development to actually providing the services to the health service.
Okay, but television involves many areas. I don't know, telemonitoring is one of these. Telemonitoring can be the main way to arrive to general physicians, because they can do that automatic process, arrive to each patient and review the state of each one. Do you have some experience like this here?
Well, there are pilots, but there is no institution in Norway that says that now we're going to do this kind of service, for instance, for heart disease. So there is no single institution that says, well, we offer this service from A to Z.
What?
So it's every institution by themselves, basically. So, and maybe that's not true.
But I also understand the point in the sense that at the end the technology should be inside the institution and you don't need any additional. I mean, we are not talking about telesecretary because some people is using a PC just to send an email or just to handle the data.
The general practitioners in Norway, they all have EHR system, and they have done that for like 20 years or so. But the majority of those systems is not very good. Lunch.
Time. I think we can continue this.
Yeah, we can continue
Please
this
ask
discussion
if there's
outside
any
now, lunch is out, and we will keep the next section will be around 4. Okay? You are coming by